we have to start. We have about 11 people in the house. Good afternoon, everyone. Welcome to our usual noon meetings. Today we have Dr. Maria Jose, who will be talking to the role of student preferences and facility reputation in rural health recruitment. Maria is a medical doctor and a public health consultant here in South Africa. She has worked primarily in many areas, including primary, district, and tertiary health facilities, and also HIV clinical trials. She has had a stint in academia as well. She convened undergraduate medical programs, and she has also received a lot of awards, including grants. She received a UCT Innovation Grant, established a student laptop donation program, and she has published on academic development. She holds an MPH in health economics with the degree was awarded with distinction, and she is a 2018 Mandela Washington Fellow. Through that, she was awarded a USAID grant. She has a lot of interest, but more importantly, in human resources for health, and that speaks to what she is presenting today. And she's consulted on many projects, for example, on Compassionate Birth Project, Youth First, and the Madagascar Economic Development Board. So I have a pleasure of welcoming Maria to talk to us at this noon meeting. You have I've spoken a lot about you. I wish I could speak more, but let me give you more time to present than talk more about you. So it's a pleasure to have you, Maria. So the floor is yours. Thank you.
Sure. Thanks so much, John, and thank you for inviting me to give this presentation, and welcome to everyone who's joined us. I'd like for the session to be an interactive session. So if you've just joined, please go ahead to the chat and interact with us. Tell us more about yourself. Where are you joining us from, and what role you're here in? Perhaps you're a student, a facility manager, perhaps you're a researcher. We'd love to know who we have in the room with us today. And I'd also love if you could each share in the chat one thing that helped you choose your very first job. My presentation today is really looking at medical students' first job. So let's use this opportunity to reflect on what made us choose our very first job. So for some people, that might be that you've, I'm going to quickly stop my screen sharing for 1 second because I need to switch off my camera. Here we go. All right. All right, there we go. So when you decided on your first job, perhaps you chose a place where your other friends were working, or perhaps you chose a place that had a great boss or that paid you well. We all focus on different things when we're looking for work. And for medical students, their internship might be their first real job. And we're going to look at how a student's preferences as well as facilities' reputation actually influences that decision. As you know, there is no perfect job. In every job, we have to make a trade-off between the things that we care about and what the job provides. And these are the trade-offs that we're going to be focusing on in this presentation. But first, I want to look at the context of this issue. First of all, we acknowledge that the health workforce is a critical building block for our health system. And furthermore, that there's a lot of inequality in terms of healthcare access between urban and rural areas. It's estimated that in South Africa, 3% of public sector doctors work in rural facilities, and that is where 33% of our population lives, in rural areas. And so because of this inequality in healthcare access, there is also a related poor health outcomes that we are seeing in rural areas. For the purposes of this piece of research and today's presentation, we're going to work with this definition of rural as an area more than 2 hours travel from road, from the nearest urban center, and an urban center would then be a place with a population of more than 250,000 people. Finally, rural medicine is considered unpopular choice because of its isolation, and there's a perception that there's a lot of poor infrastructure in and amongst the rural areas. So this is the background around which we're coming to this question. I also don't want to assume that everyone in the room is familiar with the process of South African medical training. So I want to take a few minutes just to explain this process in detail, and then I'm going to zoom in on exactly which part of this process this piece of research aims to address. So in South Africa, we have an undergraduate medical program. That means straight after high school, one can enter medical school. And most of our programs now are a 6-year program. There is the exception of postgraduate students who join medical school. Some of them do a 3-year program if they already have another degree. Upon graduation, the medical student who's now graduated needs to undergo a period of internship, which is supervised training for 2 years. And thereafter, they would do an additional 1 year, which is known as a community service year. They have independent practice during that time, and they are contracted to work in a government facility. Finally, once they've completed that, they are able to independently practice medicine in South Africa. So at that point, a person might decide to open their own practice. They might decide to specialize. They can then decide to practice however they want. So for today's research and today's presentation, we're specifically going to focus on this decision, moving from medical school to internship. So this process is handled by the National Department of Health. They have an online application process where all the graduates from all the medical schools across South Africa have to use an online platform and put their first 5 choices of facilities that they want to do their internship at. Then the National Department of Health will then allocate graduates according to how many posts each of the facilities have. And as you can imagine, the facilities that are in the metro cities, so Cape Town, Joburg, Durban, those facilities usually have way more applicants than they have posts. So in that case, they have put in certain rules about how many cities you may apply to. Only one of your choices may be in a metro city. The rest of the facilities you choose need to be in other smaller areas. In general, only about 25% of posts or less are in rural areas. And interns who work in rural areas do earn an additional rural allowance. So that is over and above their base salary. So what we've come to realize is that there is really a lack of information about what would make one choose one rural facility over another. And what the National Department of Health has created is a website where they list all the facilities that one could do one's internship at. And then you could go to that website and you could search for a facility. So as you see in the screenshot, you could search for facilities based on whether they provide rural allowance, whether they provide accommodation or not. This is one system that students are using to get information before they make this decision. When they click on one of these hospitals, they'll then be shown a review of that hospital, which is probably written by someone who worked at that hospital at some point in time. So here you see an example of the description of the hospital, and on the right-hand side, you see a certain star rating on certain aspects of the hospital, like teaching quality, academic support, medical supplies, and so on. Now, we're going to revisit this screenshot at the end of this presentation, and you will see that what is currently available actually does not give students the kind of information that they are looking for. So in this research that we undertook, the main questions that we wanted to find out was, what are the rural facility attributes that the final year medical students value? And when faced with conflicting attributes, what are the trade-offs that they would be willing to make? I'd like to emphasize here that we weren't interested in what would make a student pick a rural hospital over an urban hospital. The reason being that urban hospitals are overwhelmingly popular. Instead, what we're really trying to get at is what would make one pick one rural facility over another rural facility. And what are the lessons that facility managers themselves could learn from this? We then wanted to know to what extent gender, career intentions, and previous rural medicine exposure would influence the kind of attributes that students were looking at. And finally, in monetary terms, how much would a student value each facility attribute? So the methodology that we were looking to answer those questions was a discrete choice methodology that included performing literature review on DCEs that were conducted in other low and middle income countries. We then conducted our own focus group discussions with final year medical students in the 2018 cohort. And then finally, we conducted a discrete choice experiment, which was an online questionnaire with the final year medical class of 2019. This research was approved by the UCT Ethics Committee as well as the Department of Student Affairs. In terms of the literature, what do we currently know and what do we currently use in South Africa? We do have a number of policies that we have in place for rural recruitment. First of all, as I mentioned earlier, we have community service. So during the community service year, doctors would be allocated to generally more disadvantaged areas. And during that 1 year, they do get paid. So it is a more costly policy option. It is mandatory. You have to do that here, but it does result in higher staff turnover in those types of facilities. Another program that we've had for a number of years in South Africa is the Mandela Castro program, where South Africans students are trained in Cuba for a period of their training, and they then return to South Africa and they work back a certain number of years in lieu of their training. Again, it is a costly program, and there have been some concerns that perhaps their training in Cuba may not be locally relevant to the disease conditions that we have in South Africa. The other program that we have that I've also mentioned is around rural allowance. So at the time that the study was done over 2018-2019, a rural allowance was approximately 10% of the intern's base salary, and that was then increased if they were at an even more rural hospital, which was called deep rural. So we'll talk a little bit more around those terms. But in general, the rural allowance is thought to be more effective when it's coupled with other non-financial incentives. There is also housing provision, which is an incentive that has been researched in other countries, and it's found not to be very effective in terms of recruiting people to work in rural areas. And finally, a more newer approach has been to specifically recruit students who come from rural origins. And that the effectiveness of that approach does depend on the context. So there is conflicting literature on that. The discrete choice experiment methodology is based on rational utility theory. So that theory basically says that the people making the decisions, in this case is medical students, they're rational individuals, and they're going to choose an internship placement which yields the most utility for them. So it's this that we are trying to estimate, and we're able to estimate that and actually quantify then the relative importance of health facility attributes. When we conducted the literature review on DCEs that were done with healthcare workers in other countries, there were certain facility attributes that came up. In this Cartesian plane, we plotted those attributes that were mentioned in literature, and then we went and did our own focus group discussions. And we wanted to see how many of that which is mentioned in literature was relevant for our students in the local context. So we ran 3 focus group discussions with a total of 15 students. And during that time, we mostly focused on open discussion. The focus group was recorded and transcribed, and then a thematic analysis was done. So what you'll find here in the top left-hand corner, we've plotted those attributes of a rural facility that were mentioned in literature, such as a facility being close to school or a partner's work, access to Wi-Fi, in-service training, and having a very social atmosphere in that facility. However, these were not supported in the focus group discussions which we ran. The next set of attributes, rural allowance, housing, physical safety, and availability of equipment, were repeatedly mentioned in the literature as well as in the focus groups which we conducted. And finally, in the bottom right-hand corner, are 3 attributes that we haven't actually seen mentioned in literature, but that came out quite strongly in the focus groups which we hosted. And that is, students really cared about having personal protective equipment available at the rural facility. And their main concern at this point, this was obviously before COVID happened, their main concern was actually around occupational tuberculosis exposure. The second point that was not mentioned in literature, but which we came across, was the actual extent of practical experience that they would gain at a facility. That was really important to them. And finally, the seniority of their supervisor. So they actually really cared about who it was that was supervising them. From this list of attributes, we then had to whittle it down to a manageable number of attributes to include in our DCE questionnaire. So we actually excluded certain attributes that were considered to be more personal factors rather than facility factors. And we excluded those attributes that weren't supported in our focus group discussions. So the attributes that you see on the right side of your screen, those were all the ones we included in our questionnaire. And I'm going to go through each one in a little bit more detail so that you can understand. So for the first attribute around supervision, students really cared about whether they were being supervised by a medical officer, which is a person who is registered for independent medical practice but has not gone on to specialize in a specific field, or whether they were supervised by a registrar, that's someone who's a specialist in training, or whether they were supervised by a consultant, that is someone who is qualified as a specialist in their field. So those were the three different levels that we had under supervision. And I will show you the different choice scenarios that we presented to students that illustrate these three levels. In terms of rural allowance, the baseline amount that we gave as a reference level was 4,000 Rand a month, which was what the rural allowance was back in 2018. We used that as our reference. And then we also presented to students two other levels. The one being an 8% increase, which is based on historical wage increases. And the final level, which was a 20% increase on the base rural allowance. And we came up with that amount because in the focus groups, students said that a 20% increase might motivate them to choose one rural facility over another. In terms of accommodation, students cared about whether they would be living in subsidized doctors' quarters on the hospital premises, or whether they would be required to rent their own private accommodation. In terms of resources, they wanted to know whether there'd be daily stockouts of key resources that they use day in and day out, like gloves, syringes, and suture packs, or whether such resources would be available daily. So I just want to make it clear that each of these levels of each of these attributes came directly from the focus groups that we conducted. The last three attributes, practical experience. This is really important. Students wanted to know whether, as interns at a facility, they would be limited to merely filling out forms and taking bloods, or whether they would be able to do that as well as more advanced procedures. And the example they gave is a lumbar puncture, which is a more advanced procedure. They were quite concerned about hospital safety. So whether a facility had frequent reports of theft, hijacking, and protests in and around the hospital or not. And finally, occupational hazard. They wanted to know whether or not they would have N95 masks always available, and not only the mask, but that it be correctly fitted N95 masks. And this spoke to their fear of contracting tuberculosis at work. So using these 7 attributes, we then created a questionnaire. So as part of the design of the questionnaire, we made use of D-efficient design. And that is a design method that seeks to maximize efficiency by producing more information with fewer scenarios. Because if we included every possible choice scenario and every possible level, the questionnaire would be too long and would be too much cognitive load on the participants. So that's why we use the D-efficient design. The questionnaire itself was unlabeled, and what we mean by that is we merely presented students with a hospital A versus hospital B scenario. We didn't give the hospitals names like Groote Schuur or Tygerberg. We just used hospital A and hospital B. Secondly, we did not have an opt-out option. And the reason for doing that is because internship itself is mandatory. So one does need to make a choice and choose a hospital. And so one could argue that this was a forced choice in that respect. As the questionnaire was done online, sawtooth software was used to generate and conduct the questionnaires. It consisted of 15 choice sets and 12 demographic questions were included. So the final questionnaire was then piloted with 25 students, and the wording for each of the levels and the attributes and descriptions were tested and clarified. In terms of the population that we were looking at, the final year medical class of 2019 included some Cuban trained students as well. So their final size was 224, and the questionnaire link was then shared with all of them online through their student emails. And I was present in all their classes to encourage questionnaire completion. I just wanted to share with you a screenshot of what the questionnaire looks like. So first we had a page just defining and explaining each of the terms that we used in the questionnaire, just as I had done ahead of time. And then what you see on the right hand is the kinds of choice sets that students were presented with. So it says on the top, if these were your only internship options, which would you choose? Rural Hospital A, and then it's described according to each of those attributes, and Rural Hospital B, again described on each of those attribute levels. So a person would have to sit and read these two options carefully, and depending on what they cared about, they would then either select Hospital A or Hospital B. So they had to answer 15 of these kind of choices. So for this DCE, we did use a mixed logit model to estimate the likelihood of choosing a job alternative based on the attributes. The results. In terms of the demographics, we had a sample size of 193. That means approximately 86% of the class responded. So we had a non-response rate of 13.8%. So if you look at the demographics of the class, the mean age of 23 is conducive with an undergraduate degree. Majority, 2/3 of the sample was female, and the Western Cape was the province of origin that was most prevalent in the sample. We see most of the respondents do come from urban areas and were not married. Most of the respondents did not have child dependents, and most of them did have some sort of undergraduate exposure to rural medicine. So that came in the form of either an elective or that they actually had a faculty-based placement at a rural facility. Most of the participants were not provincial bursary holders. We asked that specifically because if you have a provincial bursary, you're then obligated to work back in that province to work back the bursary that you received. Only 7 of the sample were actually Cuban trained students, and encouragingly, most of the participants, about 98% of them, said that they do intend to complete internship. A bit more than half of them already knew that they wanted to specialize, and there was about 35% who were still undecided. If we look at our main effects model, what we're really focusing on here is that on the left column, you see the reference level. That is then followed by the remaining attributes. And then in the middle column, you see the coefficient that was estimated. So to interpret that, a larger coefficient translates into a greater likelihood of choosing a job alternative that has that attribute level compared to the reference level. So I just want to highlight these 4 that are in yellow. What is being said here is that advanced practical experience, being able to do more procedures, is preferred over the reference, which is a limited practical experience. And that is statistically significant at the 1% level. There you see the asterisks indicating that. Similarly, working in a hospital that is safe, that has few incidents of crime and unrest, is preferred over the reference, which is an unsafe hospital. Working at a hospital that has correctly fitted N95 masks is again preferred over working in a hospital that in fact has no face masks, or that has poorly fitted face masks is actually less preferred than a hospital that has no face masks. And finally, work in a hospital that has basic resources available is more preferred than working at one that does not have basic resources available. So those 4 attributes are what stand out in our main effects model. The next 3 models are looking at specific interaction terms. The first of which is gender. We find here a difference between what female participants said versus what male participants said. The female participants, if you look at hospital safety, that coefficient is much greater for the females compared to the males. So the females really care about hospital safety to a greater extent than their male counterparts. Similarly, for advanced practical experience and for having basic resources available, the females cared about those 3 to a greater extent than the male participants. Now, if we look at the sample according to whether they want to enter general practice or whether they want to specialize, here we see an important difference. Those people who already know that they want to specialize, they care about being supervised by a consultant, that is, being supervised by a specialist during their internship, more so than someone who is not currently thinking about specializing. In contrast, someone who already wants to join general practice, they care about hospital safety to a greater extent, and they care about having basic resources available to a greater extent. Finally, we compared groups of those who have had some sort of rural medicine exposure during their undergraduate training versus those who did not. And here we see another important difference. Those who already have been to rural areas are looking for hospitals that are having safety to a greater extent than those who have not been to a rural exposure. Whereas those who don't have an experience of working in a rural facility, they're looking for a place that already provides them with housing. And that might be because they don't know what housing is available in rural areas, and they would feel a lot more confident if that was provided to them. So in summary, we can say that males and females valued hospital safety. It was their highest weighted attribute, but it was more so for the females. And that female medical students also valued housing provision a bit more, and that they valued basic resources, correctly fitted masks, and advanced practical experience to a greater extent than their male counterparts. In terms of career intentions, those who intended to specialize gain more utility from being supervised by a consultant and gaining practical experience, while those who tended to join general practice valued hospital safety and the provision of basic resources to a higher degree. Medical students with rural medicine exposure valued supervision by consultant and hospital safety more, whereas those without undergraduate rural medicine exposure preferred having basic resources and housing provided. Another analysis which we did is known as marginal willingness to pay, and that basically looks at quantifying how much does a final year medical student willing to pay to work at a rural facility which has a certain attribute level in comparison to a facility that has the reference attribute level in cold hard cash. So let's look at what these results tell us. In the third column, you have a currency amount. That means for advanced practical experience, on average, a student is willing to pay 2,645 Rand to work at a facility that will give them advanced practical experience, compared to one that would limit them to merely filling out forms and taking bloods. That's equivalent of 2/3 of their rural allowance, which they're willing to pay just for that experience. Importantly, if you look at the last row, correctly fitted N95 masks, on average, students were willing to pay 1,980 Rand to work at a facility that would give them correctly fitted N95 masks. That's about 50% of their rural allowance that they're willing to forego. And that's actually really important, especially now as we talk more about personal protective equipment. Finally, we did have to do some validity checks on this research. We did find that as we presented the choice sets in the questionnaire, option A was always on the left side of the screen and option B on the right side of the screen. And we did notice that there was a left-right bias, and that was at the 5% level. We also tested for participant fatigue to see whether their last set of choice set was different from the first 5 set of choice sets that they made. And we didn't find any evidence of participant fatigue. In terms of the limitations of this research, our sample size is quite small for a DCE. And as I mentioned, we didn't give them an opt-out option, and there was fixed questionnaire administration. So this does limit the comparability of this DCE across other contexts. In this discussion, I'd like to highlight these 4 facility attributes that came out quite strongly in this research, which is facility safety, practical experience, having basic resources available, and finally, personal protective equipment. Having basic resources available in a rural facility is challenging, as they are often situated far away from supply depots, so stockouts are common. In terms of personal protective equipment, this was a new attribute that was identified in the study, and which specifically spoke to occupational tuberculosis exposure. But now, as we're living in a COVID world, it's just as relevant than ever before. The point of practical experience is important because often rural facilities do provide you with a lot of practical experience. And that is a natural selling point, which students are looking for. To the final point of facility safety, you will notice that in recent times, there have been numerous newspaper reports highlighting incidents of attack and violence happening in our health facilities. So physical safety is a key concern, especially there's a perception that rural areas are more unsafe. And it could just be a perception. Perhaps the numbers don't back it up, but that is a perception that students care about. in terms of the COVID context that we find ourselves in and healthcare workers being on the front line of that, the key effects of what came out in this research is that personal protective equipment, the price of that has surged this year due to higher demand. And yet, infection control in facilities is of utmost importance. Furthermore, since COVID started, we're seeing an increase in stigma towards healthcare workers, and the World Health Organization actually has released a report on attacks on healthcare facilities and healthcare workers related to COVID-19 and the stigma around that. They're being evicted from their homes, they're being denied services, they're being assaulted, and so on. So in response to that, the WHO has issued a charter to encourage healthcare worker safety. This came out just now, about 2 weeks ago, and I would encourage everyone to go and have a look at that if you haven't seen that yet. It basically focuses on 5 key areas, especially the synergy between healthcare worker safety and patient safety, implementing better occupational health programs, protecting healthcare workers from violence, which is a theme that came out quite strongly in this research, improving mental health and psychological well-being, and finally, protecting healthcare workers from biological hazards, which again speaks to the issue of the PPE. So in conclusion, the study's objective looked at that heterogeneity and preferences of students, and it showed us that rural allowance isn't the only thing that we need to be focusing on, and that these other facility attributes are actually really important. And furthermore, that if we're recruiting people, we need to take into account quite a number of other factors. Importantly, I want to highlight that students are making decisions about internship based on incomplete or completely minimal information about the facilities that they're choosing, and that needs to change. The next steps I would suggest is, well, this study was a stated preference study. It would be nice to look at the revealed preferences, that is the actual choices that people make, and see how that compares to what choices they say they'll make. We also need to look at tailoring the messaging that we use to attract graduates to rural areas. And finally, in terms of facility reputation management, that needs to be a more active process because it's really denting recruitment efforts. Coming back to this review that I showed you at the beginning of this session. This review, when viewed through this research that I've just presented, this review doesn't say anything about the things people actually care about. The stars on the right-hand side don't tell me anything. I don't know what 1 star means or what 3 star means. So we need to actually change how we communicate the reputation of a facility. That brings me to the end of what I have to say. I'm going to go ahead and switch off my screen sharing, and I'll take a few questions now. Thank you.
Thank you very much, Maria, for that excellent presentation. Just to wrap it up, it's basically, or to give a summary, is that we should look beyond rural allowance in terms of attracting health workers. It may not just be for doctors, but all health workers, generally speaking, to rural areas and underserved areas. So it's a very useful piece of research looking at the move towards universal health coverage, or NHI, in the country. It's very, very useful. And I like the fact that facility safety, wearing provision of protective equipment, gaining practical experience, and having basic resources are key issues. And the issue that women face more of these challenges than men is really something that we need to address and to reduce inequalities. So colleagues, I'll open the floor to questions. You can raise your hand or drop something in the chat box. Let me figure out who is raising their hand. Seems to be no raise of hand. If you pick it before me, Maria, you can go ahead, but I cannot see any hand. Okay, and I cannot see any question in the chat.
Oh, I see Virginia raised a hand. Go ahead, Virginia.
Yeah, thanks so much, Maria. It was a fascinating presentation, very clear, very innovative. I really liked what you did and how your methods as well. I just wanted to, I think you come up with some really interesting findings. But I just wanted to check whether you considered people's place of origin as an incentive for them to choose to go back to rural areas. You know, that you raised it initially in the literature review about if people come from rural areas, they're more likely to go back to them, but with a question mark. Whether, you know, if people's have families in the rural areas, they would prefer to go back to that particular rural area as opposed to general rural areas, and what your thoughts on that were. Thanks.
Sure. Thank you for that question. You'll notice when I put up the slide about attributes that showed up in the literature, proximity to family was one of those attributes that showed up in the literature. And yet when we did the focus groups, that seemed like it came up in some focus groups, but it was also seen as not really a facility attribute, if you understand what I mean. That is more of a personal attribute. It's not something that a policy maker can necessarily do anything about, except if, as I mentioned earlier, you're actively recruiting from rural areas. And so when we then did the DCE questionnaire, we did have one of our demographic questions was, are you from a rural area, an urban area, an informal area, and so on. So that yielded very few people as coming from rural areas in that class cohort. That's the 2019 cohort. I think we had less than 20 people. So that sample was actually very tiny. So I couldn't then further tell you anything more about those 20 people because that was too tiny a sample. But yeah, I think we need to follow up on that more because I know the faculty does try to look at recruiting from rural areas. So I think over time we will have more information to see whether or not that makes a difference. This specific study can't answer that question though.
Okay, just following on that, I'm aware of a PhD from UKZN that is exploring precisely this thing, that if you give people from rural areas who are brought into the system and as high school students and have an experience of a hospital, gives them a bursary, they have to go and then find themselves a placement, and that is very successful in bringing that student back to the hospital. So that is a policy making sort of thing that could be done. That's there's a partnership between the province, the hospital and schools in that area to promote school graduates to study health sciences and then return. So that's really why I'm raising the question, because I do think that there could be some policy implications for something like this. Thanks.
Thanks. I saw another hand now. Is that Nsiki? Go ahead.
Thanks, Maria. Lovely presentation. So, I mean, I just wanted to say that, I mean, the findings are interesting, and I was wondering if the gender of the participant had any influence in the choices that they made around, preference for a particular area. Because the issue of safety has become a critical issue for female practitioners. I mean, as we know, the risk for being harassed and increasingly now sexually assaulted is becoming a concern, and in fact is persuading people to consider alternatives to rural areas and other underserved areas because of the fear that the spaces that they will be working in will not be as safe as what you have in the urban settings.
Yes, thanks for that, Nziki. Yes, we definitely did find in the sample that female participants had a far greater preference for safety of facility compared to the male participants. So I think that echoes the concerns that you've raised. I think the point that I also want to make here is that this type of methodology, the DCE, it's really used a lot in marketing studies. So in the private sector, companies want to know what their customers think of their products, not only so that it can affect what products they make, but also so that they better know how to market it. And I think that that's something that we in the health sector are pretty terrible at. We don't really think about marketing, and we don't think about marketing facilities. So if there's anyone here today present who specifically works at a facility, who specifically is involved in HR and recruitment and so on, I'd like to plant a seed within you to encourage you to think about how your facility is being perceived by potential staff. And are you telling a strong story to potential staff around what you're doing to ensure their safety? Yeah, I think that there was another hand up now. Gavin, I see you, Gavin. Go ahead.
Thanks, Maria, and thanks for a lovely presentation and very nice, clear results there. So look, you may have covered this earlier on because I lost a bit of connectivity during the methods. But what is interesting is that your key findings, that you have a safe facility, both physical and infectious disease, which is a well-organized, well-resourced, properly run facility with appropriate supervision and with the opportunity to gain experience in various areas are the prime things that will make students want to go there. The problem is, of course, rural versus urban is relative. And so if urban facilities have those features, then surely students might want to choose that rather than rural. And so there's nothing really differentiating them from rural. And you may have done it in your methodology, but so now how would the rural facilities then compete against the urban that are proficient in all those areas?
Sure. Thanks, Gavin. Yes, so I was trying to sort of emphasize that in the first half of the presentation, which you might have missed, which is that we specifically didn't want to pose the question of urban versus rural, knowing full well that A, most of our posts are in urban areas, and B, urban areas provide so many other benefits unrelated to your actual working environment. So we didn't feel that there was more to be added or any actual value in asking the question of, would you pick hospital A, which is in a rural area, versus hospital B, which is in an urban area? Instead, what we wanted to look at is how come some rural facilities are better at recruiting people than other rural facilities. What are they doing right? What is it about their reputation that they're getting right? Because there are facilities that our students are excited to go to that are in rural areas. And so what this study is really trying to get at is what are those facilities doing better? And again, I want to emphasize it's not just about whether or not you have resources. It's about whether people know about it. How much of a story are you telling about the working conditions at your facility. As I showed right in the beginning, when students are making this decision, they have very little to go on. They phone a friend, and if their friend tells them that your hospital is terrible, that's it. That's how they're making their decision. So at the level of facility managers, it's very demotivating to think your rural facility needs to compete against the urban facility. It's not realistic, and it's super demotivating. Instead, I would say, how is your rural facility holding up against other similar rural facilities? And how are you, as a facility manager, taking charge of the reputation of your facility? That's really what I want to plant a seed for and learn more about. Thanks for your question, though. Were there any other questions? Shri, I see you. Go ahead.
Hi, Maria. Thanks very much. I just wanted to find out, the next step would be a revealed preference study for, the people that filled out your questionnaire, and then thereafter, what were their experiences and would it correlate? But sort of having done junior clinical time, do you think that revealed preferences, do you have an assumption as to how it would change compared to what people assumed was important for their junior clinical time? Or so were you sort of, did you think that the responses were quite accurate for things that clinical staff actually deal with? Because you were talking to students that hadn't worked full-time necessarily. Do you think their opinion would change after they started working?
Right. So I'm hearing two questions there. The first question, what you said at the end, would students' preference change once they start working? So some of the literature that we reviewed was for doctors who are already working and then making subsequent career decisions. And so what they were looking at is slightly different. Their preferences were different. Also, they were in different life stages. They were older. Some of them had partners. Some of them had children. So perhaps that could be explaining why what they cared about was a bit different from what our cohort of students were caring about. So it would be interesting to follow them up or to do a similar study further along in their careers. The second question that you had was about revealed preferences. So just to make sure everyone understands, so revealed preferences would be actually measuring what facilities people actually put down as their choice in real life and comparing that with what they've said in these hypothetical scenarios. I think one of the challenges with revealed preference is the fact that our choice as students is actually limited to what Department of Health tells us we can choose from. And students know this. So during our focus group discussions, they said that they're really aware that they need to play a certain game in order to get the facilities that they want. So they are quite strategic about the choices that they make. And that's not about their preference. I want to just make that clear. That says nothing about their preference. That tells you that they're making certain decisions based on the external control which the Department of Health has on this allocation process. That doesn't really tell us about what they want as people. So that's sort of my gripe with revealed preference in this case. I don't really feel it would tell you much about what the people want. It'll just show you how they're kind of gaming the system to make it work for them. Yeah, so is there any other questions?
Thank you very much, Maria. I think we've kind of hit the hour mark already, and very, very useful engagement. I saw in the chat box people commenting the study, and there seemed to be scope for further work here. My own comment or observation is regarding the willingness to pay estimates that you got. Perhaps you could look at WTA, which is willingness to accept as a closer way of interpreting the results, because you could look at it as how much someone would be willing to accept to live in a certain condition that doesn't seem perfect. So the reason being that that individual would use that amount to pay off for, it's just like saying, I can take this like hardship allowance, if what you're going to call it that way. So if you phrase it in terms of willingness to accept, then you can as hardship allowance that people are willing to accept to live in the not so good conditions that you gave, rather than willingness to pay to who, to the facility, or to, you get what I mean? So yeah. Great. So if there are no other questions and comments, I want to thank everyone for coming here. Thanks to Maria for that excellent presentation, and we hope to see you at our next noon meeting. Bye-bye, everyone, and have a nice day further.
Thanks. Bye.
Thanks.
Bye-bye.
Thank you.
Bye-bye.
Thanks, man.
Thanks. Bye.
Bye.